This is a shorty on demand as opposed to the longies. I will do as well. I'll try to keep the content of these to under 15 educational slides and the length no more than 15 or 20 minutes. These shorties are for those of you, like me, that want information in short chunks, and they will cover a sign, symptom or some other phenomenon rather than a major topic. But hopefully you'll also want to look at longer presentations of subjects that interest you. Hope you enjoy. Hello again. This is to establish my credentials as a teacher. I trained as a PT in England sometime in the Middle Ages and moved to Canada in 1975. I now live in Mexico and Canada. I am a fellow of the Canadian Academy of Manual Physical Therapy. I've presented at numerous national and international conferences on manual therapy, had a textbook published by McGraw-Hill, and I've published a video series on manual therapy, as well as writing book chapters and articles. I'm owner and sole teacher of Swodium Institute in Canada. I am a partner, co-founder and director of Curriculum at Impact in the USA. In my younger days, I was an instructor and examiner for the Orthopedic Division and chair of its examination and education committees, and I was the director of academics and teacher examiner with NAOMT in the US. As with everybody who teaches, I have a healthy ego, but it doesn't go in the direction of melting down if I am disagreed with. So please let me know what you think of what I'm saying. Well, that's the end of the political broadcast. So now on to the topic at hand. The word immediate is used a little loosely. Given the pain mediation processes available to the central nervous system, severe pain may be delayed by an hour or so. What I mean by immediate is that the most severe pain is felt within an hour or two of the injury. Typically, with MVA, for example, the most severe pain is felt the following day, usually on waking, and this is probably caused by inflammation rather than fracture or rupture. Immediate severe pain indicates a healthy tissue disruption, a fracture, muscle, tendon, or ligament rupture likely. Accurate palpation is the differentiating technique, as you do not want to apply movement or isometric testing to a fracture. Nobody's going to get hurt in this collision. These guys are built for impact. Your patients are not. The purpose of this presentation is to look at the causes of sudden onset of post-traumatic severe pain and to remind you that, first of all, not all seriously injured patients go to the emergency room, and that when they do see their GP, not all severe pathologies are recognised and investigated appropriately. As an example, the Dens fracture is the most common cervical fracture, and it is also among the most commonly missed even when it's been x-rayed. As most PTs can now see the patient direct from the scene of the accident or from the field, you have an extra dose of healthy responsibility put upon you, should you care to do so. It is necessary that you are very careful in how you assess the patient. Don't touch them until you really know that they are capable of tolerating your touch. Certainly don't do active movements until you know that there isn't a major injury to them. Take care, look after your patients, and refer out when you're not sure what's happening. The flowchart that this presentation is centered around is not intended as a set formula for you to assess post-traumatic patients. I don't like protocols, I don't like clinical guides. I think you need to learn the principles of what you're doing and then use your brain and clinical reasoning. So I'm not going to insult you by giving you a protocol. Rather, these types of mind maps, concept charts, flow charts, algorithms are pretty good learning tools, and I think if you go through these, it will help clarify what I'm saying to you about this. So this is not to basically remove your responsibility for using your intellectual gifts in clinical reasoning to come up with a solution to the problem. Please use it in the way it was intended, and that is as a learning guide. you'll see that many of the boxes end up or terminate as make a decision, and this is because context is king. There is no way that any instructor can possibly foresee all clinical circumstances you're going to encounter. So you have to take all of the information you gather from a patient, the accident mechanism, the onset of pain, where the pain is, what the pain is associated as far as other pains and other symptoms are concerned, and so on. And then use that information as part of the entire problem-solving process and come up with your own conclusion. You have sole responsibility for what happens to the patient in your clinic, morally, ethically, professionally and legally. It is a responsibility that cannot be abrogated, so it needs to be your number one consideration, particularly in post-traumatic cases. These takeaways should be your constant mantra when dealing with the patient. Start at the yellow block. We'll move straight down to neck pain. Before that though, if the presentation breaches the Canadian C-spine rules, then it should have been x-rayed at a minimum. If it is a direct contact patient, or if the physician failed to order imaging, you may need to obtain one. But you also need to know where to obtain it: emergency, urgent care, or the patient's physician. Immediate onset of central neck pain indicates a midline structure damage. The central ligaments are candidates, but more likely and more serious are high cervical fractures. The transverse ligament is life-threatening, but it is rarely torn. The ALAs are probably going to cause ipsilateral rather than central pain, and a rupture is not life-threatening anyway. So a vertebral fracture is the most likely and most serious. Assume this is what happened and get the patient to the ER by ambulance. If the pain is posterolateral, and if there is a torticollis, then assume it is a fracture and send it to the ER. If there is no torticollis, then a hemilateral fracture is less likely, but palpate the muscles to see if there is a tear, and if there is no severe tenderness, assume a fracture. You need an x-ray, but whether it is by the ER or the patient's MD is your choice. Very occasionally, the pain will be experienced anterolaterally, often in addition to posterior neck pain, and your immediate thought is that they have torn the sternomastoid, and they probably have, but they could have damaged the artery. Before touching them, look for Horner syndrome, hemilateral anophthalmos, anhidrosis, small ptosis, facial flushing and meiosis. If there is a Horner syndrome, it needs to be referred. The ER is arguably the best place unless the MD can see them immediately. If there is no Horner syndrome, palpate the sternomastoid by pinching across it for significant tenderness. If it is not tender, you are running out of possibilities. You are left with considering an injury to the longus colli, so this must be palpated. If it is not tender and swallowing is not painful, it might be best to go back to the artery as a suspect. If swallowing is painful, you may be looking at a visceral injury to the pharynx. These three pictures depict aspects of Horner's. I'm sorry, I couldn't resist the cat, but it actually does have Horner syndrome. The lower picture shows clearly the flushing on the side of the face compared to the other. This isn't Horner syndrome, but Harlequin syndrome, which is an exertional effect, but the phenomenon is the same thing. The upper right photo shows the difference in pupil size and the ptosis of the right eye. Both are small, and in fact with meiosis, you may only be able to see it in a darkened room, the difference in sizes. If the Horner sign is present, it indicates that the sympathetic chain has been damaged. And if the sympathetic chain has been damaged, it's quite possible that the carotid artery has been damaged as well, as they both run together up the neck. When palpating the sternomastoid in these cases, avoid pushing backwards through it that way and palpating front to back. You're pretty much over the carotid artery for a good part of this palpation, and if there is a problem with it, you could displace some debris and cause an embolus. Rather, pinch medial to lateral across the belly. So your thumb and finger is doing that, and you're staying away from the deeper structures. And this is going to be safer for you and the patient. If there is a head injury, severe sudden onset of head pain can easily be from a fracture. When I say head pain, I'm not referring to a headache, but focal head pain. Look for evidence of basilar fractures, such as raccoon eyes and battle sign. There may be a brain injury, so listen out for cognitive difficulties such as drowsiness, memory problems and concentration issues. If these are present, refer to the ER, providing they were not present before the accident. Ask a relative if possible. You can also check with the MD to see if that is the patient's normal state. Look for extensive bruising and palpate the painful area for swelling, tenderness and possibly crevitus. Battle sign and raccoon eyes occur when blood from a basal skull fracture drains to the area. Battle sign is bruising over the mastoid process, and usually the area is soft and spongy. Raccoon eyes is in the name. These are very discrete black eyes, but with the conjunctiva remaining white. Both are evidence that there is a basal skull fracture that is allowing blood to pool in these areas depending on how gravity has taken it. If the conjunctiva are red, it would indicate that there's a fracture near the orbit of the eye. Neither sign is one that you really want to delay getting the patient back to the doctor with. Direct trauma to the face may result in fracture. This is clearly not as worrying as cervical or skull fractures, but it should be dealt with as soon as possible. Look for extensive bruising, reverse contours of the face, rhinorrhea, which could indicate leak in CSF, paresthesia and swelling around the eyes and forehead, and bulging of one eye. Carefully palpate over the painful area and look for severe tenderness and note any crevitus. Any and all of these could indicate a fracture, and the patient should be referred to the MD. If there is any paresthesia or rhinorrhea, the emergency room may be more appropriate. I hope this presentation was of use to you, and it wasn't too elementary. If it was, let me know. Also, let me know if there are subjects or topics that you'd like me to talk about to you. You can email me at jimswodeme@gmail.com or jim@swodeme.org. What I'm going to do is I will set up a live chat for anybody who wants to join it, and I'll try to remember to record the chat for later on so anybody who wants to look at it. But what you could do, which would probably help somewhat, and it might save you the embarrassment of asking a question when you don't want to, is you can email me any questions you may have and I'll address them on the live chat, and also, as I say, keep a record of it so that you can have access to it. Anyway, I hope this was of use. I hope you enjoyed it. I hope it wasn't too amateur. It's my first one, and I hope that they're going to get better. Loads of hopes here. Thank you. I look forward to seeing you again. Bye.